From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Welcome to this JAMA Clinical Review podcast. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing renal cell carcinoma. I'm joined today by Dr. William Kim, who is the Rush S. Dixon Distinguished Professor of Medicine in the Division of Oncology at the University of North Carolina. Dr. Kim is the lead author of the JAMA Narrative Review on Renal Cell Carcinoma, published in the August 28, 2024 issue of JAMA. Welcome, Dr. Kim.
Thank you very much. I'm looking forward to discussing the topic with you.
Well, Dr. Kim, renal cell carcinoma is a malignancy where we can cure patients, so this will be fun to talk about today. But before we talk about how to make that happen, can you tell us about the exciting basic science that is related to renal cell carcinomas that led to the 2019 Nobel Prize in Medicine or Physiology?
Yes, of course. The Nobel Prize in 2019 was shared by three people, Sir Peter Radcliffe, William Kaelin, and Greg Semenza. And it was primarily for their work on understanding how mammalian cells sense oxygen. So over decades of work, these groups were all really critical to identifying that the von Hippel-Lindau tumor suppressor protein, which is actually a very important protein in kidney cancer, serves to degrade a transcription factor central to the hypoxia response called the hypoxia-inducible factor alpha, or HIF alpha. Indeed, one of the key clues to this connection between the von Hippel-Lindau gene and this HIF protein was that patients with von Hippel-Lindau disease, so those are patients that carry a germline VHL mutation that's passed on from generation to generation. These VHL patients were actually predisposed to tumors that are all known to be hypervascular. And so these include things like retinal angiomas, cerebellar hemangioblastomas, and then kidney cancer of the clear cell histologic subtype. And so their discoveries were really that this VHL protein in the presence of oxygen was able to recognize this key HIF alpha transcription factor and degrade HIF alpha. However, in the setting of hypoxia or low oxygenation, or in the absence of VHL, which is found in about 90% of clear cell kidney cancers, the HIF alpha subunit was not able to be either degraded or recognized by VHL. And so this led to the stabilization of HIF alpha subunits, which are transcription factors, as I mentioned earlier, and could turn on a suite of genes which are important for how mammals adapt to low oxygenation, but also can be pro-tumorigenic in specific contexts. And one of these key genes is called VEGF, or the vascular endothelial growth factor. And that is a very pro-angiogenic gene or protein that turns on blood vessel growth. And this is, as we'll likely talk about sometime during the podcast, one of the key targets for treating advanced kidney cancer. I'd like to finally mention that what makes part of this story of the VHL-HIF interaction so neat is that kidney cancer therapies have really been developed based on a better understanding of the molecular biology and the genetics of how mammalian cells sense oxygen.
So basically, if I've got this right, the body doesn't sense oxygen when oxygen is present. And the response is that it makes blood vessels or does things to adapt to that perceived hypoxia.
Exactly. So in cells that lack VHL, which are in clear cell kidney cancer, the tumor cells, they are essentially in a sort of pseudo-hypoxic state. So they think they're hypoxic and turning on all these genes that, again, are important for blood vessel growth, but also can result in growth of tumors.
Well, let's switch to the clinical features of renal cell carcinoma and maybe come back to what you mentioned, which is that understanding the biology has had a big impact on treatment. In your review, you noted that only 10% of patients have what was traditionally the classic triad of flank pain, a palpable abdominal mass, and hematuria, and that most are going to be detected incidentally after some type of abdominal imaging. Tell us about the process for evaluating a renal mass, because this is certainly something that generalist physicians can initiate.
Yes, it's actually pretty remarkable that nowadays, at present really, about 37 to up to 60% of kidney cancers are really detected incidentally through abdominal imaging that was typically done for reasons such as visits to the emergency department or a motor vehicle accident or just abdominal pain. However, once one of these incidental renal masses is found, I think a generalist physician can certainly take some first steps that will expedite evaluation prior to seeing a urologist. First, I think it's important to emphasize that a CT scan or an MRI should really be done in the context of a renal mass protocol. And this is a little different than a typical contrasted CT because images are obtained in the so-called early arterial phase. And this helps to identify early enhancement, which is a key feature of renal cell carcinoma. Once a renal mass is identified, we have the framework of thinking of them as either being cystic or solid tumors. With cystic tumors, there has been a very well validated classification system called the Bosniak classification system. And it's really based on designated imaging criteria that have been correlated very well to risk of malignancy. And so abdominal radiologists will routinely report the Bosniak class of a cystic renal mass. Bosniak 1 or 2 cysts are almost uniformly benign and really require no further workup or follow-up. Bosniak 2F cysts carry a malignancy risk of about 11%, and therefore they do require repeated imaging surveillance over the next 5 years or so. If there are imaging changes that occur with these Bosniak 2F cysts that make them suspicious for renal cell carcinoma, they should be followed and treated as such. And finally, Bosniak 3 or 4 cysts have malignancy risks of 54 and 100% respectively, and are therefore treated as if they were kidney cancer. If a renal mass is solid, then treatment decisions are actually primarily based on the size of the renal mass. So renal masses that are solid and less than 1 centimeter can be followed with repeated imaging to rule out any further growth or any morphologic changes that would indicate a higher risk of renal cell carcinoma. If a renal mass is greater than 1 centimeter, then typically treatment is proceeded as if it were a renal cell carcinoma at that point.
If you diagnose a patient with renal cell carcinoma, do first-degree relatives need screening?
That's a great question, and one we often get from patients, as you can imagine, given the gravity of kidney cancer. First, I think it's important to note that the vast majority, probably approximately 90% of kidney cancers are sporadic, meaning that there's no clear inherited germline predisposition for why they developed the kidney tumor. We always need to be aware of the fact that there could be inherited cancer predisposition syndromes for these patients. And so there are 3 clinical clues that warrant further investigation for a potential germline predisposition. And those include, number 1, early onset of a kidney cancer. So we consider early onset typically less than 50 years of age. Number 2, if a patient has bilateral kidney tumors. Or number 3, if they have multifocal kidney tumors, meaning multiple tumors within a single kidney. Any of these 3 features would warrant a referral to clinical genetics for evaluation. There are actually now a number of well-known germline genetic syndromes that are associated with kidney cancer. And frankly, we continue to find more. Even during my fellowship, I remember the Birt-Hogg-Dubé syndrome being described when I was an oncology fellow. And I would just put a plug in for the group at the NCI Urologic branch led by Marston Linehan. They've really been highly dedicated to defining germline genetic causes of kidney cancer. And so if a clinician appears to have a family that doesn't have a clear cause of the germline predisposition, sending them to the NCI Urologic branch would be a good idea.
In your review, you had a table that showed the stages of renal cell carcinoma, and I was impressed that stage 1 includes tumors up to 7 centimeters, which just seems really large to me. but they can be cured. And when you send a patient to a urologist for an initial evaluation, what kind of options does the urologist have to offer those patients?
Over time, it's been nice to see more and more options for these early stage patients. The main treatment options for localized kidney cancer really include a partial or radical nephrectomy, meaning removal of either a portion of the kidney or removal of the entire kidney, including Girota's fascia. Some renal masses can be treated with ablative techniques such as thermal or heat ablation, or even cryoablation, which is freezing of the tumor. And then it's important to note that some of these renal masses can be followed with active surveillance as well. So not every patient with kidney cancer requires an intervention immediately up front. As I mentioned, a radical nephrectomy is typically done by a urologist, and the entire kidney, including Girota's fascia, is removed. A partial nephrectomy tries to leave a portion of the kidney in place with just removing the tumor and some adjacent normal tissue. The urologist obviously is the one who ultimately decides whether they can perform a partial nephrectomy, but some features that suggest this is possible is when a kidney tumor is exophytic, meaning sticking outside of the kidney on the surface. And if it's not adjacent to the renal pelvis, those are really two big critical factors for partial nephrectomy. Finally, I would note that the majority of these surgeries are now done laparoscopically or robotically at most major medical centers. And so the recovery times for these surgeries in the past, which were quite large, are now relatively quick. Cure rates with local therapy correlate primarily with stage. So with stage 1 tumors, as you mentioned, which are less than 7 centimeters, have a 94% 5-year cancer-specific survival, whereas stage 2 tumors, which are greater than 7 centimeters in size and are limited to the kidney, have a 90% 5-year cancer-specific survival. So as you remarked on, these are actually highly curable tumors despite being relatively large in some instances.
Dr. Kim, you mentioned early on that these tumors can be quite vascular. Is a biopsy of the tumor required before deciding which option between partial nephrectomy, radical nephrectomy, or ablative therapies to take?
When surgery is going to be performed, either a partial or radical nephrectomy, a renal mass biopsy is typically not done, since the pre-test probability of something being a kidney cancer is quite high. In the cases where we're going to perform ablative techniques, we often will do a renal mass biopsy to confirm it is renal cell carcinoma. And in most cases, that's primarily because these are done on smaller tumors. And so the pretest probability of them truly being renal cell carcinoma is often lower.
Let's say you have a patient with limited disease who has a procedure with curative intent, and you have to decide how to follow them. First off, is any additional treatment required? And then what is the frequency of surveillance and the type of surveillance that you do?
Sure. For the majority of patients, it's very important to note that majority of relapses will occur within the first 5 years after their therapy. So in general, as oncologists, we tend to cease surveilling patients after 5 years. That said, we occasionally do see patients who relapse 10 years after their curative treatment. Follow-up is primarily radiographic and dependent upon the stage of the primary tumor. These recommendations are not based on clinical study results, but are really primarily based on guidelines put out by societies such as ASCO or the NCCN. And so with stage 1 renal cell carcinoma patients, we recommend abdominal imaging through either CT or MRI with contrast if possible within 3 to 12 months of surgery, and then annually for 5 years after that. Chest imaging, either through chest x-ray or a CT scan of the chest, should also be done annually for 5 years. For stage 2 tumors, a very similar protocol for surveillance is recommended. So a baseline abdominal CT or MRI, again with contrast if possible, should be done every 6 months for the first 2 years, and then annually for up to 5 years or longer again, depending on discussions with the patient. And then chest imaging should include a chest x-ray or a CT annually for, again, at least 5 years if possible.
Well, let's talk about the patients who do have a recurrence. How have you leveraged the basic science to develop treatments for patients with advanced disease or with metastatic disease and follow-up?
We are really talking about patients with stage 4 or metastatic kidney cancer. And I think it's always first important to acknowledge the gravity of that situation. And so in realistic terms, stage 4 kidney cancer at this time is not curable. It is highly treatable, however, and we always emphasize that to the patients. And we also emphasize that there are some long-term responders, particularly to immunotherapy-based regimens for our patients. Historically, kidney cancer has really been refractory to conventional cytotoxic chemotherapy, sort of the chemotherapy you think about that we use for many cancers nowadays. Clinical trials decades ago documented that kidney cancer just does not respond to these conventional chemotherapies. We don't really understand why this is true, but we know it is true. In the late 1990s and early 2000s, kidney cancer researchers began to appreciate a number of things. Number one, as we covered earlier, kidney tumors are highly vascular in nature. Scientifically, it was discovered at that time that approximately 90% of clear cell kidney cancers had inactivation or mutation of the VHL gene, the von Hippel-Lindau gene, that resulted in stabilization of the HIF-alpha protein and turning on of a number of genes, a key one being the vascular endothelial growth factor or VEGF gene. And this entire pathway was really documented to be critical as drivers of kidney cancer growth. And the hypothesis was born that if we inhibited the pathway, and at that time, what was available to the field was inhibiting VEGF-A with the use of a monoclonal antibody called bevacizumab, or inhibiting the VEGF receptor, so the receptor that VEGF binds to through small molecule tyrosine kinase inhibitors such as sorafenib, sunitinib, pazopanib, et cetera. We have approximately 7 to 8 of them now. And these were all tested in patients with advanced kidney cancer and shown to induce both responses and in some trials demonstrating prolongation in overall survival as well. And so VEGF receptor or VEGF pathway blockade has really been successful based on understanding the molecular underpinnings of kidney cancer and really did revolutionize kidney cancer care in the early 2000s. In fact, I'd say that almost every advanced kidney cancer patient likely is treated with some type of VEGF pathway inhibitor during their journey at some point. In the last decade, immunotherapy has really contributed significantly to the survival of our patients as well. So alongside melanoma, kidney cancer has always been considered a cancer that's responsive to immunotherapy. You may remember yourself the use of high-dose IL-2 in our advanced kidney cancer patients in the 1990s. This high-dose IL-2 stimulated cytotoxic T cells to try to result in responses in the cancer. But as you know, this was also balanced by a high level of toxicity. So while there was efficacy, there was also a high level of toxicity. And so it was a treatment that was selected for specific patients and unfortunately not applicable to the majority of our kidney cancer patients. More recently, immune checkpoint inhibition has become really a cornerstone of therapy for advanced kidney cancer, either as monotherapy, blocking the PD-1 axis, or in combination with a VEGF receptor tyrosine kinase inhibitor, or even dual blockade of the PD-1 and the CTLA-4 axes. These treatments in general have become the first-line therapy for all of our patients and really been highly successful for these patients. Overall, it's been really nice to see that the therapies that are in current use have really been developed based on a deep understanding of the molecular biology of kidney cancer.
When you talk about these newer therapies for advanced disease or metastatic disease, are you talking about survival in terms of months or years?
Great question. So we stratify these patients with metastatic kidney cancer into 3 prognostic groups, either poor risk, intermediate risk, or good risk. And this is dependent upon a number of features, including both laboratory values as well as clinical features. The patients that are grouped into the poor risk category do only have a median survival in the range of months. However, those that are in the intermediate or good risk categories have median survivals that are certainly in the 2+ year range.
Well, Dr. Kim, is there anything else you'd like our listeners to know about renal cell carcinoma?
I don't think so. I think we've covered the majority of the points that I would hope a generalist could appreciate, and hopefully they find the review interesting.
Well, thank you, Dr. Kim, for joining us today to talk about renal cell carcinoma. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.